soul. Not the end, just re-inspired. This is me, my life rewired.
Well, it's a great day to have a great day, and welcome back to another episode of Life Rewired. Today, I'm honored to be joined by Dr. Topher Stevenson. He's the founder of Rincon Physical Medicine and Rehabilitation. Now, Dr. Stephenson is a board certified in both physical medicine and rehabilitation and brain injury medicine. And he has dedicated his whole career to just helping people recover from some of the most complex and often misunderstood injuries. Welcome to the program, Dr. Stevenson.
Hey, it's a pleasure. Thank you for having me here, Rob.
Yeah, the pleasure is all mine. So tell us a little bit about what background has led you to become into this field of brain injury medicine.
Oh, wow. It's a long and winding road. So I started out my career in medicine getting my emergency medical technician's license when I was a college student. I actually, I have a degree in English literature. And my summer job was running whitewater rafts on the Colorado River. And I got paid, I think it was $3 extra per day if I had my EMT license. So I thought, $3 a day, of course I'm going to do that.
Right.
And so I got my EMT license and continued to run rivers as a commercial guide. Then I graduated, and I was really looking for the next stage in my life, what I was going to do next. And I ended up working on a hotshot crew for the Forest Service. So for your listeners that don't know, a hotshot crew is a 20-person crew, and they fight the hottest parts of wildfires. So they're the ones who are sent in to cut fire line and do the big back burns. Oftentimes they're left out for days at a time with relatively little support. And it's a really dangerous physical job. And so I was the EMT for this crew of 19 other wildland firefighters. And well, I did that for a couple of seasons. And as I was thinking about, okay, well, what's my next step beyond firefighting? I realized what I really enjoyed about it, other than, being outside was amazing and seeing incredible parts of the West. But what I really was enjoying was taking care of other people. And that got me thinking about medical school. And long story short, I went back to school, took all of my pre-medical courses, ended up going to medical school, graduating. I then did my training in physical medicine and rehabilitation. So I'm what's called a physiatrist. And I did that training at UC Davis in Sacramento, had absolutely incredible opportunities to work with kids, work with adults. I had great mentorship and training opportunities. And so then there I am, a freshly minted physiatrist with any number of different opportunities ahead of me.
Wow. That is so awesome. What are some of the biggest misconceptions that you see as a healthcare provider that other healthcare providers have about traumatic brain injuries?
Oh, so you know this intuitively, and a lot of your audience knows it, that this is the invisible injury. Mm-hmm. And we're talking about an injury, and this is if physicians and clinicians haven't had very specific training, experience, and exposure with traumatic brain injury, they may miss the subtle signs and symptoms that go along with it. They may not understand how to develop a care plan, how to work it up, how to diagnose it. And that's by no fault of their own. I'm certainly not trying to call people out here.
Right.
It's really an education and awareness issue, even in the medical community. So the understanding the context of a brain injury, understanding that it affects that human being at multiple different levels is key, because that starts to help you build a framework to understand how to identify and optimize the rehabilitation, which, by the way, that the root of rehabilitate is really the phrase to return to life. So how to identify and then rehabilitate that person so that all those levels of their world that are affected by a brain injury, that effect is reduced. As you know, we don't have a cure for brain injury.
Right.
What we do have is, in the brain injury medicine community, an understanding of how this affects a patient and how to bring together the right team to treat each patient individually.
Yeah. Do you feel like some of this is contributed to the lack of continued education after people graduate med school?
I would say there's probably a combination. If we there's continuing medical education, and everybody who is in medicine, whether it's a physician, a nurse practitioner, a physician assistant, therapist, speech language pathologist, on and on and on,
Hmm.
all of them have dedicated themselves to becoming lifelong learners. That's just the nature of the beast. Now, whether they really dive into brain injury and understanding all the facets of a brain injury that can be there and be present and be
Yeah.
affecting a patient, it totally depends. So there's this continuing medical education part, but really there's also just a baseline awareness and foundational education that goes along with really being aware of this disease and this disease process.
Right.
So I was incredibly lucky in that my training, we had dedicated TBI clinics. I got to diagnose and treat TBI for the pediatric population, for the adult population, the geriatric population. And I got to collaborate with these incredible clinicians, neurosurgeons, neurologists, neurooptometrists, neuroradiologists. And that really informed my education and, well, frankly, the direction of my clinical interest. And I mean, frankly, it's totally affected my personal and professional development and trajectory.
Yeah. How often do you hear a patient come in and say, I've been to 8 doctors, and they all say, you seem fine? I'm sure you hear that quite often.
You look fine.
Yeah.
You look fine. They don't see a broken arm. They don't see an amputation. They don't see a limp.
Hmm.
They don't see obvious signs of trauma.
Right.
And so, Rob, my approach when that patient is sitting in front of me in my clinic is to just start with the basics. And well, let me back up.
Okay.
When I'm bringing on a new clinician that I work with,
Hmm.
that works in my clinic, I explain to them that if you want to get really simple about it, if you want to get back to first principles, there's only one question we have to answer when we sit down with a patient, and that is, what does this patient need?
Mm.
And to do that effectively, we need to be open to their message. We need to just start with really broad, open-ended questions. What happened? What then? What next? How's this affecting you? How's it affecting your work? How's it affecting your relationship with your spouse? So, to answer your question, Rob, I hear this all the time. And I guess it really speaks to the not only the invisible nature of the injury, but also our historical approach. And when I say we, I'm talking about Western medicine trained clinicians
Yeah.
and their approach to brain injury. And a lot of that you absorb from your mentors. You get taught in your schooling, but there's so much that gets passed on that is subtle and not so subtle, particularly during your training. And I work with plenty of physicians who still say, oh, you know, if somebody's had a brain injury, they should be over it by 6, 8 weeks. And if they're not, there's something else going on. And I have to stop them and really talk to them about, look, let's look at the current best literature out there. We
Mm.
understand that is not the truth. You're
Yeah.
hanging on to a framework that is suspicious of the patient, that is not taking at face value
Hmm.
their report of their symptoms, and it's not taking into consideration what we know now about the structure and the function of the human brain, particularly a human brain that has been rattled around inside of a skull.
Right. I hear way too often in our support groups. Um, One of the most common things that they say is, my doctor says I'm faking it. Several people have said that. And that just breaks my heart because I know way too many people that they can't even work anymore or they can't communicate with their spouse, you know, and that doctor may see them on a good day. We don't, you know this better than I do. We don't, every day is a question mark. I have no idea how bad my symptoms are going to be day to day. I might see my neurologist today and I'm on top of the world. Now,
Yeah.
tomorrow, I might not be able to get my words to come out of my mouth. So for them to say you're faking it, I mean, it just breaks my heart.
And it should. And frankly, it's not an appropriate answer. I'm offended by that answer. Shame on that clinician, shame on
Hmm.
that doctor for saying that. That's just not true.
Yeah,
And if they don't have the expertise and the experience, or at least the innate ability to ask themselves, hey, could this be a brain injury? Is there something going on that I don't fully understand? Who do I bring onto the team that can help answer some more of the questions that I have and my patient has? If a doctor just writes that patient off and says, I think you're faking it, or look, this is all in your head.
hmm,
Um, well, let me tell you, if that were a family member of mine and they called me up and said, "Hey, Topher, here's what my doctor told me," frankly, I would tell them to find somebody else, another doctor who
yeah,
is willing to spend the time, peel back the layers, collaborate with all of the different specialists that may be required to optimize the functional independence of that patient and to optimize their quality of life. And
exactly.
so and when you say, Rob, when you say, gosh, it breaks my heart when I hear this, I couldn't agree more. Not only does it break my heart, but frankly, I mean, let me be blunt here. It pisses me off. It's
Hmm.
inappropriate. It's not right. And it's not listening to what the patient actually
Exactly.
has to say.
Hmm. I tell everybody that I hear that from, I say, think of it like going out to eat. There are good waiters, and there are bad waiters. If your waiter is not a great waiter, run.
Yeah.
There's a lot of other people out there that's more than willing to listen to your symptoms and diagnose you properly.
Yes.
I was a victim of this myself. My wife will tell you, when I had got my brain injury at the very start of COVID, I had to see the neurologist on my own. And that was an undertaking.
Oh,
The first question he asked me was my birth date. I didn't know it. He slammed his pen on the table and said, "The questions are going to get harder from here." I almost bawled on the spot. So my wife said, "Nope, we're finding another neurologist."
yeah. Yeah. Thank you. And, I would encourage your listeners to understand that it's not just a neurologist that can diagnose and treat brain injury.
Yeah.
You've got options out there. I know primary care physicians that are very astute when it comes to brain injury. I'm a physiatrist, a PM&R specialist. There aren't the problem with physiatrists are is that there are very few of us. I mean, there are, by my best calculations, there are fewer than 100 board certified physiatrists that are subspecialty board certified in brain injury medicine in the state of California.
Wow.
And
That's not
so,
enough.
and no, and when you've got this huge population,
Yeah.
and the people, the citizens of California just don't have enough access. So a neurologist that understands and treats brain injury can be remarkable.
Hmm.
And I collaborate with neurologists, and I have neurologists on my team. I have amazing other clinicians, also speech language pathology, neurooptometry, vestibular physical therapy, psychiatry, neuropsychology. There are all these other players that if they know brain injury, if they focus on brain injury from their perspective, can be invaluable part of the team.
Hmm. I encourage people to really do their homework. A lot of people don't even realize there are dentists that specialize in brain injury.
Yes. Okay, so I've got a couple of great dentists on my team, and where I utilize them is in my patients that have survived a TBI and they have a sleep disorder because of the change in the structure and the function of the brain.
Yeah,
So when you rattle around a human brain inside of a skull, you're going to change the structure. When you change
absolutely.
the structure of a human brain, you change the function. Sleep
Hmm.
is an incredibly complex, it requires a very complex network of circuits throughout the brain. Inevitably, well, we understand that in patients with an acute brain injury, the large majority of them have a sleep disorder because of that brain injury. Well, if you're not sleeping well, tell me that you're going to get better from a fresh brain injury? Not a chance. And I'm sorry, I'm being a little bit hyperbolic here,
Yeah.
but understand that, so I get, I'll order a sleep study on my patient. And if that comes back positive, I then send them right to two people. One is a neuropsychologist that can do cognitive behavioral therapy for insomnia, which is the gold standard for sleep disorders. You got to start with the basics. But
Yeah.
then I also send them to my sleep dentist, and they help get them into either a CPAP or a device that will help keep their airway open so they're breathing better
Okay.
through the night. Inevitably, that patient comes back and says, "Wow,
I feel
that's
better.
amazing. I'm sleeping better.
Yeah.
I'm getting, like, I wake up and I don't feel quite as fatigued. I'm
Hmm.
not I'm not hitting that wall at 11 a.m., 1 p.m., 2 p.m. where I am done for the day, and I might even be done for a couple of days." Understanding that this is not a cure, but it's one of the
It's a good
parts.
start. Yeah.
Yeah, so I love that you know that, and I love that you're getting the word out there. And I gotta say, I've got these sleep dentists who are just, I rely on them, and they are just so good. My patients come back and they're like, "Dr. Stevenson, thank you for that." I'm like, that is such a hurdle that we are
Yeah.
now over. And we can now focus on these other components of my rehabilitation.
Hmm. More people should know about that, especially like for me, I have the sound sensitivity.
Oh, yeah.
Yeah. So drills and all that. No
Oh,
thanks.
so, and Rob, so another specialty that I've really, and I'm a little embarrassed to say that it took me this long to figure this out, but I've started collaborating with an audiologist.
Oh, yeah.
So, in my patients with a brain injury, an audiologist is a lot for a lot of them. An audiologist is a critical component of their rehab. So we're checking for hearing loss associated with whatever their injury mechanism was.
True.
We're checking for chronic tinnitus, ringing, that high pitched ringing in the ears,
Yeah.
which for some patients with a brain injury can be completely overwhelming.
Yes.
And we're looking at testing their balance. And so then you're bringing in the vestibular physical therapist, you're bringing
Hmm.
in the audiologist, you may bring in a neuro-otologist, so an MD that specializes in the inner ear and balance. And so here we're starting to build this framework to really look at that whole person.
It surprises me the number of people that will tell me, well, I've never been to this or that or whatever. Like, why wouldn't your doctor or your neurosurgeon or neurologist suggest that? And some of them will say, well, this didn't do any good, so it's probably no point in trying this. Why is there no point in trying something?
Yeah, you
I don't
got it.
understand that.
Rob, I totally get it. And, it's so interesting. So, and I'm going to get back around to your point here. Um, Jeff Manley, who is a neurosurgeon out of the University of California, San Francisco, um, just an incredible thought leader and clinician. And he this guy is amazing. He is part of this group that's called the Track TBI Consortium, TRACK.
Okay.
And the Track TBI Consortium is made up of all these academic medical centers that diagnose and treat brain injury across the United States. And what they have done is collectively, they've come together and said, hey, TBI is a chronic condition for many of our patients. It affects huge portions of the population. It has a massive economic impact. We need to know more. And they have designed incredible studies. They've published papers that, frankly, are changing the way we diagnose and treat brain injury. So, one of the papers that Dr. Manley just presented, this was just published it was about 6 months ago in Lancet, so a very high quality medical journal. And the presentation and the article in that, he says, look, we need to stop. I'm sorry, they say, the consortium collectively says, it's time to stop calling brain injury mild, moderate, severe,
Mm-hmm.
because it has no value. And frankly, for patients that are on the are more severely affected, so bleeding in the brain, intubated,
Yeah.
neurosurgical procedures, coma, it leads to clinical nihilism. And this gets back to your point where, it's really a clinician saying, oh, I don't think that's going to work. It's not worth exploring. So that's one of the outcomes of using these very antiquated labels for brain injury, because they tell us these labels tell us nothing about how that person is affected, the effect on their life, their family, their community, their job, how they experience their world. And so they have, they were very, frankly, I think they were really brave to just come out and say, stop it.
Mhm.
Don't use mild, moderate, severe. Because when you tell a patient they have a quote unquote mild traumatic brain injury, what are you telling them? You're telling them they should get over it really
Ah, you're
quickly. And
fine.
if they're not over
Yeah.
it in a few weeks, then they're faking it or it's something else. Come on, we can do
Mhm.
better than that. And then on that severe end, what that track TBI consortium figured out was that for those patients with a label of severe acute traumatic brain injury, we, the medical community, were withdrawing care too early. And that really gets back to the phrase that Dr. Manley used in one of these presentations, which was therapeutic nihilism, looking at that intubated patient who's had a big neurosurgical procedure, who is still in some sort of coma or altered level of consciousness, and saying, you know what, there's no hope, and removing the care. Because what they have done, one of their studies, there's a whole or a subset of their studies, they realize that even those patients with the quote unquote severe TBIs can make significant improvement. They can have a quality of life that is, it's different, it's
Yeah.
new, it's not what their old baseline was, but it is a quality of life worth living. And that has been expressed to them by these patients and by their families.
Yeah. You hit the nail on the head with the labels, because here's something that I hear a lot in our support groups. Oh, they said I just had a concussion. Like, it's not just a concussion. You hit your head. Your brain sloshed around and hit your skull.
Yes.
Part of your brain was
Yes.
damaged. There's nothing concussed about that. You are a brain injury survivor.
Yes.
And the hospitals are the worst about wanting to admit that you have a brain injury. And I don't understand that.
Well, and Rob, I've got some perspective I can give you because I had this discussion yesterday.
Okay.
Um, about 50% of patients that go into an ER with complaints of a head injury, we're going to just call it a head injury,
Okay.
they and they are later diagnosed with a TBI, are not, they don't leave the ER with a diagnosis of a brain injury, of a
Mhm.
traumatic brain injury.
Yeah.
They are subsequently diagnosed. So here's the thing. I had lunch with a colleague that he's an emergency medicine physician and a pain management physician. And he is fantastic with identifying brain injuries and understanding the context. But he said, look, Topher, here's the deal. My colleagues in the ER, they are trying to answer just a couple of questions. And those are, does this patient need to be intubated? Do they need a ventilator to breathe for them because something catastrophic is happening in their brain? Increased pressure from bleeding, herniation of the brain, catastrophic, deadly issues.
Hmm.
Um, and do they need a neurosurgical procedure to take care of that? Do they need an emergency surgery to save their lives? And that's the context that many of our ER colleagues are using. And I will tell you, it's unfortunate that our medical system has developed in a way that that first line of medical evaluation and treatment is set up that way. It's I don't want to I don't want to overly harsh when it comes to my emergency medicine colleagues. The flip side of the coin is I do think as a system, we can all do better. And
Yeah.
things are improving. I will tell you, talking to my colleague yesterday, when he's doing shifts in the ER, he understands how to have the conversation, how to make the diagnosis, how to have the conversation with the patient, and then what recommendations to give that patient that are going to be the most high yield for them, and really get them going down the path of, hey, a brain injury has been identified. Let's get this further worked up and treated. It shouldn't happen in the ER. It can be diagnosed there. But as long as the patient is safe, they can progress down that path as an outpatient.
Yeah. Do you think that maybe oftentimes the patient isn't ready to hear that diagnosis at that moment, though?
That's an interesting question. So maybe they're not ready to hear it. Certainly, a pattern that I see in my clinic is a patient will come in and say, hey, I was in this crash and I got knocked out, or I got my bell rung, by their description, by the clinical exam, I make the diagnosis of brain injury, but they, right off the bat, they don't recognize how they have changed. They may be sitting in the ER or in that primary care or urgent care office saying, God, I've got this outrageous headache.
Yeah.
I feel foggy and kind of goofy. But you don't know at that point, look, my short-term memory is shot, my multitasking, I'm irritable, my multitasking is down the tubes, I can't focus, I'm irritable, my spouse is angry with me, I'm forgetting things at work that I know how to do without even thinking twice, on and on and on. These symptoms, that patient's constellation of symptoms will progress with time. And so I don't take that initial moment or of injury or the very, very acute period as, oh, well, this has to be the limit of those symptoms. Some symptoms develop. I mean, how do you know that you're depressed because of the electrochemical changes in an injured brain? You don't know that right off the bat. Come
True.
on. That takes time to develop.
Mm-hmm.
So, I think with appropriate conversations with a patient, you can prepare that patient to start to accept their brain injury on their terms. But it has to be a conversation that starts with the patient, that is patient-centered.
Yeah.
This has to be patient-centered care. This can't be a systems-based approach. It's got to be, we've got to take our understanding of precision medicine and saying, okay, well, who is this patient? What are they coming to the table with? What did their clinical exams show? What did their biomarkers show? What did their imaging show? How does their past medical history, their genetics, their family history, a history of trauma, a history of other neurologic conditions, how is that affecting their brain injury?
Yeah.
And how is that affecting them? And that's really the context that Dr. Manley and his colleagues have laid out, is this new framework for how we talk about a brain injury.
Yeah. And another thing too is, this was my misconception when I first got my brain injury. I thought the day I left the ER, I thought that's what I'm going to be like right now. I didn't realize that the symptoms were going to come days, weeks, and months later.
Yes. And having that conversation with a patient, and it's typically multiple conversations, to be able to say, look, it's early on in your injury. We need to track your symptoms. And that's where a clinician in a clinic that's a multi-specialty clinic where they're able to track the symptom burden of that patient. They've got the tools, the processes, the procedures to be able to do that. And you can track the constellation of symptoms affecting the patient. Understanding, just like you mentioned earlier, Rob, that there are good days and bad days. And
Mm-hmm.
so being able to work with that patient and ideally with their family members as well, and have them understand that there's going to be a progression. Not only is there going to be a progression, but there are good days and there are bad days.
Mm-hmm.
And this may sound, I'm not, it's not mean, but it helps me clinically. When I have a new patient come in, I want to have them do a whole battery of questionnaires and of neurodiagnostic testing, looking at their balance, looking at their vision, the coordination of their eye movements, testing their cognition, their memory. And I really want to kind of stress test them. That's when I want to meet them for the first time, is after they've been through that. Because
Yeah.
I want to know what they look like when they've already had, frankly, kind of a stressful day. And
Yeah.
it's not that I'm trying to torture them. I'm just trying to see what their new reality is.
I don't know if this is old school way of thinking. The neurologist that I went to the first time I was telling you about, his approach, he wanted me to wait 2 years to see if I got better. And my wife said, no way. That's when she said, what kind of a guy are we going to? She started asking me questions, and that's when I told her about him getting upset with me because I didn't know my birth date. But she said, no, we are definitely going to find you some help. First thing she did was found me a cognitive therapist.
Yes, yes. God, and having a great advocate at your side is so key.
Yep.
I mean, if I could wish, I guess if I could wish one thing, it'd be no brain injuries in this world, but that's, unicorns and fairy dust, unfortunately.
Yeah.
But wishing for an effective advocate,
Mm-hmm.
that is something that it would just be so practical and is so needed. I mean, that just makes me think, I wonder if there is a way, and Rob, what you don't see over here is, on my wall, I've got a little neon sign that says, what if dot, dot, dot. And it's really the way I approach my medical practice and my personal development. And it's just, this is the optimist in me coming out. So, and this is just the way I think about things. So try this on for size. What if we developed an AI tool, and that AI tool listens into a patient's interaction with a physician, a therapist, whomever it is, in the context of a workup. And maybe there's an initial questionnaire that's brain injury related, so that that AI agent understands some context of that person. And then it gives that patient, that injured person, some feedback like, hey, looking at the current literature, I realized that waiting 2 years before there's any sort of therapeutic intervention is not the standard of care. You might want to find somebody to address your symptoms of cognitive dysfunction, memory problems, executive dysfunction, whatever it is, headaches, imbalance, double vision. And I recognize this is a really slippery slope, because you can go down that rabbit hole with
Quickly.
AI and get lost very quickly.
Yeah.
But I just wonder if there's some tool that could be developed with appropriate guardrails, sorry, that would be that AI advocate for a patient living with a brain injury. Just I'm just throwing that out there. I mean,
Yeah.
I'm clearly over caffeinated and enthusiastic about the subject matter. So
Excuse me. I like your thinking though, because I had this idea. Of course, ideas cost money, things that we all don't have. I had this idea for an app. So, say John Boycott goes and hits his head and goes to the hospital, and he comes home. He downloads this app that says, "I have a brain injury. Now what?" So then you could type in here, oh, today I'm feeling this, and just kind of like journal it each day. And then as you go along, it's going, I think you need to do X, Y, Z, or you should call this person because this person in your area specializes in this. You see what I'm saying?
that's beautiful. So let me just riff on that. Yes, and so not only could that app track symptoms, those symptoms could be logged and then presented to whomever that patient is working with, tracking headaches, uh, cognitive fatigue,
Yeah.
sleep, whatever it might be. We could come up with 100 different metrics.
Mm-hmm.
Then part of that app is the tracker, the symptom
Yep.
tracker, and then part of it is a guardrail enabled agent that can say, hey, I'm looking at the trends here.
Mm-hmm.
You might want to talk to your clinician about X, Y, and Z. That could then be put into a report because that patient living with that brain injury and they sit down with their primary care or another specialist, depending on the setting, if they've got approximately 3.5 minutes
Right.
with that clinician to talk to
Mm-hmm.
them, wouldn't that be cool to have 3 bullet points that have been collected and
Yeah.
digested through this universe of uh, symptom tracking and informed
Mm-hmm.
analysis? I love it. I love
I
it.
think it would be so great for you to be able to just to hand your phone to your doctor, and the doctor goes, "Okay, I know exactly what we're dealing with here,
And
based on what you've put in and what the trackers have put in and what AI has collaborated with. I know our next direction we should try."
I love it, man. I tell you what, we should pitch this to the Brain Injury Association of America.
Let's do it.
Um, Rob, it brings up a point. There is so much happening in brain injury right now,
Yeah.
particularly on the clinical side when it comes to diagnosis and tracking metrics. I mean, everything from the Aura Ring,
Yeah.
which is tracking biometrics like your heart rate variability, your sleep, your temperature, to newer types of MRIs that show us the actual structure of the brain and where the
Yes.
different structures may have been injured.
Mm-hmm.
We're using we bring on new, because we're a private clinic. I don't have to run through big committees and get approval from managers and stuff to bring in expensive new equipment or new tools. So a couple of things we've just started using: blood-based biomarkers to help with the diagnosis of traumatic brain injury.
Really?
So at the North American Brain Injury Society, or the internet, also the IBIA, International Brain Injury Association, at their
Wow.
annual conference, a couple of world-renowned researchers said, "Look, it's now time to be able for the right clinicians to be able to use these blood-based biomarkers as a well, it's a biomarker. It gives you biologic information about the existence of a brain injury."
Wow.
So we're using that. We're also getting ready to use a technology. Frankly, it's new to me, but it's not. Look, sometimes I'm slow to get on the train, but it's using an iPhone to look at the reactivity component of the pupils. And so the
Really?
camera is good enough in an iPhone now that we can have a patient use an app to measure the reactivity of their pupils, and that helps us understand the context of a brain injury. Is asking, does the reactivity of this patient's pupils match somebody with a brain injury, or does it match somebody without a brain injury? And
Okay.
so, I mean, think about that. A blood test that can actually be, we're having patients do them at home, if you can believe that.
Wow. Unbelievable.
This blows my mind, Rob. The number of tools that we're able to put into our toolbox to be able to gather more data, be more effective in our conversations and our coaching of patients that are living with brain injuries. It's just,
Wow.
this is an amazing time.
That is so cool. Now Susie Johnson can go, look, Bob, the phone says I have a brain injury. So stop,
Yeah.
get off my back.
Yeah, yeah. And now remember, it's got to be this technology needs to be used appropriately in the
Right.
right context, because context is everything
Yeah.
here. And your listeners know that brain injury can be subtle. That person can look normal, but
Mhm.
inside they are foundationally different.
Yeah.
And we're starting to recognize that. Even Medicare has said, look, this is a disease process. This is, for some patients, this is permanent and it's progressive.
Yeah.
So again, context is important,
Hmm.
collaboration is important, recognition of brain injury being unique to that one brain. And if there are 8 billion brains on this planet, it's not, I've seen one, I've seen a billion. It is, if you've seen one brain injury, you've seen one brain injury.
Yep. I say that all the time. That's what I say because they're like snowflakes. I've not
Yeah,
met one person that's had exactly identical symptoms that I have.
exactly.
It
Exactly. Now,
amazes me that some people have to immediately go on disability and other people go back to school and become doctors and lawyers and I'm fighting with my phone to I've got 4 contacts in my phone for the same person. So, so everybody's different.
yeah, I get it, Rob. I
Yeah.
get it. Rob, this has been an incredible conversation.
Yeah.
There's so much more to talk about.
Yeah.
I would be happy to have my team arrange another time for us to
Yeah.
talk. Um,
Absolutely. I think this would be a great conversation going forward. Maybe if we want to meet once a month or once every other month and put out some great content for people to learn from and to because this today has just been probably the tip of the iceberg.
it is, and I will tell you, just there are some things happening in California right now on the political front, on the uh, big corporation front, that will be catastrophic for patients injured in car crashes.
Mm.
So I would love to dive into that on another, in another session.
Yeah, absolutely.
It is. I'll just give you a little bit of a preview. There is a rideshare service that is trying to get the California state constitution changed in a way that will make them a bunch more money, hold them much less responsible for injuries
Oh wow.
sustained in a car crash, and radically limit the care that can be accessed by patients who are underinsured, uninsured, or not happy with the care they're getting. So uh, this is an asteroid hurtling at Earth, as far as I'm concerned. When I think
I
about it from
agree.
my perspective as a brain injury medicine specialist,
Uh-oh.
this is something that, well, in another interview, I described it as catastrophic and inhumane.
Absolutely. Yeah. Hey, it's been a great conversation today. I look forward to having more conversations with you. Guys, if you have enjoyed today's broadcast, make sure you give us a like and subscribe. And we look forward to talking with more with Dr. Topher Stevenson in a few weeks.
Terrific. Look forward to it. Thank you for the opportunity.
Thank you.
This is me, my life rewired.